So our next speaker to address the biologic modifiers and therapy in pancreatic neuroendocrine tumors is Dr. Emily Bergsland from Ucsf. And there she is. And Dr. Woolen picked up about 15 minutes for us. No.
Okay, well, thank you very much. This works out really, really well because Dr. Woolen gave a really nice introduction to some of the things I'll be talking about. I'm going to be focusing on pancreatic neuroendocrine tumors and giving a similar overview of my approach to treatment and also what's going on in terms of clinical trials. So just briefly to reiterate, what's happened over the last decade or so is a growing appreciation that pancreatic neuroendocrine tumors appear to be biologically distinct from what we've traditionally thought of as carcinoid tumors or well-differentiated tumors arising outside of the pancreas. So this wasn't the case 15 years ago when these tumors were often bundled together, but increasingly you'll find physicians focusing on where, in which organ did the tumor arise, and I'll try to explain the reason for that today. Within the pancreas, these are actually pretty rare tumors. Only about 1% of all pancreas tumors diagnosed in any given year will be pancreatic neuroendocrine tumors. But one of the things that's important to keep in mind is because these are relatively indolent, relative to the more common tumor, pancreatic ductal adenocarcinomas, if you look at the number of patients living with pancreatic tumors, about 10% of them will actually be living with neuroendocrine tumors. So it's not as rare as you might think, and this is due to the fact that patients can actually have a relatively good outcome relative to pancreatic ductal adenocarcinomas. So unfortunately, most of these are metastatic at diagnosis. I would say one key exception to this would be insulinomas. Those are insulin-producing tumors, and of course, patients are really symptomatic from that and have hypoglycemia or low blood sugars, and those tend to actually be found fairly early because of that. Now, most of these don't make hormones, but of the tumors that can make hormones, as you've already heard, a variety of hormones can be made. The most common ones would be gastrin, which can cause stomach ulcers, insulin, which can cause low blood sugars, glucagon, which can actually cause diabetes, and VIPomas are very rare, but that can cause a cholera-type diarrhea. One thing I'll just mention is sometimes these tumors make something called pancreatic polypeptide. That actually typically doesn't cause symptoms, but it's something you can follow sometimes and monitor. So while these tumors are relatively indolent as opposed to the other more common type of tumor, adenocarcinoma, unfortunately, progression is the rule over a number of years, and that's something that I think we all struggle with. And one of the things to be thinking about today is an unanswered question so far, but relates to the timing of the therapies that I'll be discussing, because many patients do very well for a long time with very little intervention. So the other point I want to make before I get into the therapies is that as I mentioned, there's a growing appreciation of the differences between these different types of neuroendocrine tumors, and we're starting to learn more about the molecular drivers. This slide illustrates key findings in a very important paper that was published a few years ago looking at some genetic changes in sporadic tumors. And by sporadic tumors, I mean the ones that occur in families without an obvious inherited syndrome. We know that a small fraction of patients, probably less than 10% of patients, will have a familial syndrome, meaning an inherited syndrome like MEN, neurofibromatosis, or VHL, von Hippel-Lindau. But that's just a small proportion of patients. Most of the patients have tumors that arise for no apparent reason, and those are called sporadic tumors. If you look at the genetic drivers in those tumors, you'll see that there are these mutations of chromatin remodeling genes called DAX and ATRX. You heard a little bit about this earlier this morning. Interestingly, MEN is also mutated in sporadic tumors. That's the gene that's mutated in MEN syndrome. But about 40% of patients with sporadic tumors will have MEN1 mutations. And then also there are, in a small group of patients, about 15%, you'll see changes in mTOR pathway components. And you've heard a little bit about mTOR in the context of it being a target for everolimus. And I just want to point out in that table, these are very different drivers from pancreatic ductal adenocarcinoma. So these really appear to be very distinct tumors, both arising in the pancreas. Interestingly, though, these drivers also appear to be different than the mutations that are seen in carcinoid syndrome. So again, sort of underscoring that these probably arise through different mechanisms, and therefore perhaps isn't surprising that these tumors might be different in terms of their treatment. Although under the microscope, they look very similar to carcinoid tumors. So potentially there might be overlap in the therapies. And I think a lot of what I talk about today is going to overlap with what Dr. Wolin just spoke about. I would also like to just point out before I leave the slide that currently we are not individualizing therapies. So we aren't at a point where we actually look at the mutational profile in a tumor and then decide therapy based on that. But I think that that's the kind of thing we'll be hopefully moving towards as we get more information about whether these patients have different responses to therapy. And as yet, that's unknown. So turning to therapy, I'm going to focus on unresectable disease for the bulk of my talk today. You heard a lot about surgery this morning, and I'll come back to that at the very end. So when I see somebody with a neuroendocrine tumor of the pancreas, the first thing I think about is, first of all, whether the person can be resected, and if that's not possible, then we're looking at timing of therapy and at what point do you intervene. And I would say there are a couple of reasons to intervene. One would be if somebody has a hormone-producing tumor, even if it's not actually growing on scans, for example, but you might want to intervene to protect that patient from symptoms related to their hormone. And then, of course, the second thing is when you have demonstrable progression of disease on CT scans, or you have somebody who's symptomatic just from the bulk of their disease. So there are a couple different reasons that will drive us to choose a therapy. But I would submit to you that patient selection is very important. And Dr. Wolin alluded to this when he talked about a couple of clinical trials that have had control arms, and these are patients treated with placebo. What we've seen across clinical trials is that that patient group doesn't always do the same in each clinical trial, and you'd think they would, except that it means that probably the eligibility were somewhat different across these clinical trials. And it turns out, depending on how you select patients, you might actually be selecting for more aggressive or less aggressive disease. So patient selection is very important, both in terms of clinical trial design, but also in terms of deciding when a therapy is appropriate and possibly in determining whether or not a therapy is effective. It might be more or less effective in tumors with more or less aggressive disease, in patients with more or less aggressive disease. So I'm just going to briefly mention liver-directed therapy. There are going to be other talks related to this tomorrow. But I just want to point out this is done all the time. It's done at a lot of institutions across the country, but we're limited by the fact we don't have randomized controlled trials regarding liver-directed therapy. So I'm just going to acknowledge that we don't quite know where this fits in relative to the total body or systemic therapy I'm going to be talking about today. But I just want to acknowledge this is there. We all use it. But just understand we don't know exactly how to use liver-directed therapy relative to these things I'll be talking about next. So I'll briefly run through some of the things that are listed here. I'll spend more detail on some than others. Somatostatin analogs, Dr. Wolin has already brought this up. These tumors are characterized by somatostatin receptors. This is a hormone that all of us have in our body. It controls a variety of exocrine and endocrine functions. It mediates its receptors through, mediates its effect through 5 different types of receptors. And the point I want to make is these 5 different receptors have distinct but somewhat overlapping functions. And for some of the receptors, for example, number 4, we're not even entirely sure what it does. But you can imagine as you start to develop analogs of somatostatin, they might have different targets in terms of these 5 receptors. And that's what we're seeing in terms of drugs like octreotide or lanreotide versus drugs like pasireotide. So I just wanted to explain to you the basis for why these somatostatin analogs that are out there in trials and approved might differ from one another. And there's some evidence from what we know about how the receptors work as to why these somatostatin analogs might both reduce hormones and therefore improving symptoms, but also why they might actually have an anti-tumor effect, because these, in some cases, inhibit cell growth or they inhibit blood vessel growth, both of which are types of things that might also inhibit tumor growth. So we have two different drugs that are routinely used, at least worldwide right now. Octreotide is approved in the United States for control of symptoms, as well as Europe. Lanreotide is approved in Europe. The only approval in the United States currently is for a disease we're not going to be talking about today called acromegaly. But both of these drugs are pretty similar. They're somatostatin analogs that bind receptors 2 and 5 predominantly. And both of them have an excellent control of symptoms related to hormones. Dr. Wolin already mentioned the clarinet study. It's important in context of pancreatic neuroendocrine tumors because, as Ed mentioned previously, we knew about octreotide's anti-tumor effects in small bowel neuroendocrine tumors from the PROMID study. But we really weren't sure about its effects in pancreatic neuroendocrine tumors. We hadn't really had randomized data to support its use there. So this was a study that looked at tumors that are not making hormones of a variety of different types. So it is a bit of a mixed bag, which is one of the limitations of this study. But it's a randomized study of patients with non-functional tumors randomized to receive lanreotide or placebo. These were previously untreated patients. And the primary endpoint was looking at progression. So as Dr. Wolin said, this is the time it takes for the tumors to grow a defined amount. And that's defined by something we use called RECIST criteria. And this is what you can see. You've already seen this slide. This shows that there does appear to be improvement. If you look at the red line, those were the patients, how long it took them to have progression with lanreotide, as opposed to the blue line, which is the time it took for patients to have progression on placebo. Now, I would just point out from this study that progression can be defined in a variety of ways, but this is a very traditional way of defining progression. You're looking for a certain percentage of growth. And the point I want to make is the patients in the placebo arm in this study were not defined as having progression for 18 months. So this is 1.5 years. So this really would suggest that these patients had relatively indolent disease. On this slide, I just wanted to point out, this is a list of the patient characteristics in this study. And I wanted to point out that about half the patients had pancreatic neuroendocrine tumors, about 40 to 50 patients in both arms. In terms of tumor progression going into the study, they did look at this. They actually had patients had 2 CT scans a few months apart. And it turns out that only about 5% of patients had significant progression going into the study on those 2 different scans, which means that 95% didn't. And this is, again, an important thing because this study was really looking at a group of patients that had pretty indolent disease going on study. And then also, not surprisingly, most of these were grade 1 tumors. So these are tumors that have a very low proliferation rate, a Ki-67, if you're familiar with that term, of less than 2%. It was pretty well tolerated. The most side effects that are typically seen with lanreotide, there's a little bit more in the way of GI side effects, but generally very well tolerated and few patients going off study because of side effects. And what we saw is that lanreotide did in fact improve progression-free survival in this group of patients. I would just point out it's not FDA approved yet for this indication. We're waiting to see how that all sorts out. But I think this is certainly the first randomized data that we have that suggests that lanreotide has anti-tumor effects and can delay growth. There wasn't an obvious benefit that we could see, at least in terms of overall survival at 2 years. But I would point out that the way this study was designed, patients who were originally designed to placebo were allowed to get lanreotide later on. So in the end, pretty much everybody could have lanreotide, and that always makes it difficult to see any real difference in overall survival in patients. I wanted to stress this study was enriched for patients with very stable disease. So just keep that in mind because the effects may or may not be the same in somebody who has a more rapidly growing tumor. And we recognize there's quite a bit of heterogeneity in these patients. And then similarly, only a small group of patients had grade 2 tumors. So again, whether this data would apply similarly to patients with more aggressive tumors is hard to know. I'm just going to briefly mention the concept of, well, what if you radio-label the octreotide or the somatostatin analog? And I'm sure many of you are very familiar with this concept of peptide receptor radiotherapy. There'll be another session on this tomorrow, so I'm not going to spend a lot of time on it, just to acknowledge that this does exist worldwide. It's not routinely done in the United States, but I wanted to just let you know this is an area of intense interest. And again, how this fits in with some of the other therapies I'll be talking about in the rest of my talk is unknown at the present time, but under study. Interferon, again, just briefly to mention, this is sort of an older concept. Interferon's been around for a long time. I would say I personally used it more before we had some of the newer agents that are approved. But I would just point out that there actually is some evidence that interferon may have activity. Its use tends to be limited by its side effect profile. It can actually cause a fair number of side effects. But that said, I would say that there are some data suggesting that it can have benefit. But like somatostatin analogs, patients don't tend to have shrinkage on interferon. They tend to, if anything, have stability. And then there's some evidence that in patients with hormone-producing tumors, you can have a reduction of the hormones. But again, it isn't widely used, mainly because of the toxicity profile relative to some of the other agents out there. And there's also not a huge amount of data behind interferon, but just wanted you to at least have heard of it, because in some cases, this may come up as a treatment option. Chemotherapy is something that has been around for a long time. As Dr. Wolin mentioned, streptozotocin-based therapy is actually approved for use in pancreatic neuroendocrine tumors. This dates back to the early 1990s when it was approved. But I would say that its effects have since been called into question. Back in the 1990s, we didn't have the same kind of imaging that we have right now. We didn't have the same kind of rules about what constitutes response to therapy or progression to therapy. This was sort of early days in terms of CT scans being incorporated, and of course MRI scans were not being used back then. Subsequent studies, when people used streptozotocin-based chemotherapy, they found lower response rates. So it's been very inconsistent across studies, and certainly in modern studies. I personally do believe that streptozotocin-based therapies can have benefits in some patients, but it is relatively toxic, and that's something that needs to be kept in mind. Instead, there's been a growing trend to using temozolomide-based therapy, and this is largely driven by a retrospective study that I have listed up there by Dr. Strasberg and colleagues at Moffitt Cancer Institute. This was retrospective, so this means going back in your charts and looking at your last group of patients that was treated, and they saw a very impressive response rate with temozolomide-based therapy, and that's led to a lot of interest in using this. But I would caution everyone that prospective, randomized, very controlled trials have not yet been done, but are certainly of interest. So part of the challenge related to temozolomide is if you look at a lot of the data that are out there currently, a lot of it is retrospective, some of it is prospective. There are a number of different regimens out there that have been used. Not everybody's using the exact same regimen. There's some data that there might be an enzyme in tumor tissues that might be predictive of benefit, MGMT, but that has not been confirmed. And so we aren't currently screening people based on MGMT. We're really waiting for prospective trials. And I would point out and encourage everybody to think about this. If you're considering chemotherapy for this disease, there is a study currently open and enrolling right now called ECOG 2211, which is a randomized study comparing capecitabine and temozolomide versus temozolomide alone in patients with progressive pancreatic neuroendocrine tumors. So very, very important study, asks a very important question of is there benefit to two drugs versus one? It's prospective, very well controlled, so we should get a lot of information hopefully about this to guide our future trials and therapy. Next, I want to turn to something called VEGF inhibitors. You heard a little bit about this from Dr. Wolin. But I just want to reiterate, VEGF is something called vascular endothelial growth factor, and it's a potent regulator of blood vessel formation, which is called angiogenesis. And it turns out some very, very old data now, going back a couple of decades, suggests that tumors can't grow beyond a certain size without recruiting blood vessels, that they need blood vessels to actually grow and metastasize. And that has actually formed the basis for trying to target this process by targeting the regulators of this process. And as I mentioned, VEGF is probably the most potent regulator of angiogenesis in the body. Now, we know in neuroendocrine tumors that VEGF and its receptors are upregulated. The more VEGF that's around, it seems to inversely correlate with outcomes, so it seems to be a bad thing to have a lot of VEGF. And this is the same across multiple different tumor types. And then in animal models, if you target VEGF, you can actually see inhibition of tumor growth. So this was the basis for developing inhibitors of VEGF in the clinic. I want to point out there are a number of different ways that you can inhibit VEGF. The ones that I have listed on this screen here are actually all agents that are approved for different indications, not necessarily for neuroendocrine tumors. But there's a whole variety of ways that you can target this. One is to actually target circulating VEGF, which would be the most sort of classic agent for that would be a drug called bevacizumab, which is also known as Avastin. And then the other way that's commonly used is to target signaling at the receptor. And the common drugs, for example, would be sunitinib, pazopanib, axitinib. There are a whole variety that all sound like that. They're in the same kind of category and inhibit the receptor signaling. And then there are some other ways to do it as well, and a number of these are under study right now, including you can clip off part of the receptor and attach it to an antibody that's a circulating receptor, also known as aflibercept. And you can have an antibody to the receptor on the cell membrane, and an example of that is ramucirumab. So I just want to explain there are a number of different ways that you can go about inhibiting the pathway, and I'll talk about a few of these moving forward. So we have some very nice data in hand, which is a randomized trial looking at a small molecule oral agent called sunitinib, which blocks receptor signaling. And this was done in patients with progressive pancreatic neuroendocrine tumors. So important to keep that in mind, because these are patients that had some component of progression over the preceding year, randomized versus placebo. But there was an ability for patients, if they had progression on placebo, to cross over to the sunitinib in the salvage setting. What you can see here is a very nice delay in progression. So there was about a 5-month delay in the time it took for tumors to grow, according to our X-ray CT scan criteria. And this was statistically significant. And this was, in fact, the basis for approval of sunitinib by the FDA back in 2011. Now, while the quality of life based on the instrument they used in this study looked pretty good across both groups, the placebo and the sunitinib, there were some side effects that we're seeing that are very typical for this class of drugs. One is high blood pressure, also some fatigue, diarrhea, and nausea. Again, no survival benefit was seen, but remember, in terms of overall survival of patients, but remember, patients could get sunitinib if they were originally on placebo, so we wouldn't really expect that we would see a major difference in overall survival. Of course, we don't know from this study where sunitinib fits in with the other agents that are out there now, and that of course, contributes to the complexity in the decision-making for this disease. Now I want to turn now and talk briefly about mTOR inhibitors. You heard a little bit of this already from Dr. Wolin. mTOR signaling is within the cell as opposed to the surface, and it integrates signals from a lot of different sources. It has a variety of different downstream effects on all sorts of things like cell metabolism and survival, blood vessel growth, et cetera. Some of the mutations I referred to earlier may actually drive signaling in the mTOR pathway, so there are reasons to expect that this might actually be a reasonable pathway to target in neuroendocrine tumors. And in fact, we have some very nice data now, phase 3 data from the RADIANT-3 study, which looked at an inhibitor, everolimus, versus placebo in the same group that had been looked at in the sunitinib study. So these are patients with progressive disease in the preceding year. So not patients with rock-stable disease, but patients with disease that's been progressing. And again, there was crossover, meaning that if you were initially assigned to placebo and had progression, you were then given the option to go on the everolimus at that point. So again, we wouldn't expect to see any sort of overall survival benefit in this type of study. And sure enough, if you look at progression, there's a delay in the progression in patients receiving everolimus. That's the orange line. And you can see it's very similar to sunitinib. It's about a 5-month increase in the time it takes to have progression by our preset CT or MRI criteria. So like sunitinib, there weren't a lot of patients with overt shrinkage. So shrinkage is rare on these types of agents. Fewer than 5% of patients had shrinkage. And the side effects were a little bit different. In the case of everolimus, it was things like mouth sores, high blood sugars, high cholesterol, low phosphorus. So sort of a very different type of toxicity profile. But it was approved at the same time that sunitinib was approved, right around the same time in 2011. So I'm just going to point out, if you put them head to head, they're actually really interesting. They show very similar things. Both drugs delay progression. Neither drug causes a great amount of shrinkage in the tumor. So again, these drugs are what we call cytostatic, meaning that they typically cause just stoppage of growth as opposed to major shrinkage of tumors. The side effect profile is somewhat different of the drugs. So currently, the way we choose these drugs is often related to the patient's other side effects, or comorbidities. So for example, if somebody has high blood pressure that's not very well controlled, that type of patient would not be a very good candidate for sunitinib. If somebody has diabetes that's not very well controlled, that might be a reason to be careful about everolimus. So we sort of work with patients to decide which drug we might start with. But we don't have good data right now to guide us in terms of if there's a preferable drug to start before the other or to use after another. Those data don't exist yet because these drugs were approved at the same time. And both are very reasonable options. So of course, one of the interests now that comes out of is, well, what if you were to combine pathway inhibitors? What if you were to actually take drugs that inhibit VEGF and combine them with drugs that inhibit the mTOR pathway? And we're just beginning to see data along these lines. This is from a small study that was done fairly recently, just a single-arm study, so it's not randomized, but it led to some very interesting information. So this was with a different mTOR inhibitor called temsirolimus, which is actually intravenous, so not oral, not a pill. And then bevacizumab, which is an antibody to VEGF. So a little bit different than the sunitinib, which is a pill that you take by mouth, but also targets VEGF. And what you can see is there were some side effects, the most common ones being high blood pressure, which is expected, especially with a drug like bevacizumab or Avastin. High blood sugars were seen in patients, fatigue, low blood counts, headache, protein in the urine, and low potassium. So there were definitely side effects associated with the combination. But I think what's really interesting is you can see that there was a fair amount of shrinkage. So when I say response rate, RR, that actually means shrinkage as we define it by X-ray or CT scan. And this is a bit unusual. It's not something you would ordinarily expect with these types of agents. So it's led to some interest in exploring this further. And in fact, this type of concept has already begun to be explored. CLGB 80701 is already done. It's completely enrolled, and we're waiting for the data. So this takes patients with pancreatic neuroendocrine tumors and randomizes them to get everolimus plus octreotide compared to everolimus, octreotide plus bevacizumab. So that's the antibody I was telling you about. This study, as I said, is completely enrolled, and we're just waiting for the results from this study. So I think this will be very important to see, and we're all eagerly awaiting the results, which should be hopefully out relatively soon. So finishing up here, I just wanted to say that we've had these major advances in treatment over the past 10 years. There's so many options at this point. One of our challenges is knowing in which order to do these things. We don't know that yet. What we do know, though, is that pancreatic neuroendocrines and carcinoid tumors are probably not the same. And so that's the reason for developing these through different clinical trials and separating the patients in terms of eligibility. As I mentioned, in terms of deciding how to do this, it's really individualized at this point, whether we use liver-directed treatments or systemic therapy, choice of agent, whether it's chemotherapy or everolimus or sunitinib, et cetera. You have to really tailor it to the individual patient and the extent of their disease and the rate of growth of disease. Constantly weighing the risks and the benefits of therapy, because as I mentioned, in some cases, there are patients who do very well, at least for a period of time, with no therapy or very limited therapy, and I think that's important to keep in mind. Unfortunately, though, eventual resistance appears to be the rule. In the setting of patients who have unresectable disease who are getting these types of therapy, this is a problem. So despite all the advances that we've had, we certainly do see resistance. And I just want to point out, just as an example, I've been talking a lot about VEGF as a target for therapy, but I want to point out there are lots of other regulators of blood vessel growth. And this is just looking at blood vessel growth, and of course there are many other hallmarks of cancer besides blood vessel growth. But my point is there are lots of things that are contributing to tumor growth, not just any one factor or perhaps any one pathway. So one of the other factors that is a dominant factor that I'll just point out up here is something called basic FGF. So one of the strategies that we're taking is to, well, what if you use an inhibitor that has a broader profile of activity? So davitinib is a drug that's also a pill that inhibits VEGF but also inhibits FGF. So a study that should be opening soon is taking patients with pancreatic neuroendocrine tumors and treating them asking the question of whether davitinib has activity. This study will enroll patients to two different groups, patients who have never had a VEGF inhibitor before to see whether davitinib has activity in this group. And then secondly, people who have had a VEGF inhibitor like sunitinib and it's no longer working, and asking the question of whether davitinib is helpful in that group. Not open yet, but should hopefully be open soon, but just as an example of the types of ideas that are out there for trying to deal with resistance. So in terms of systemic therapy, I just wanted to give you an overview of the clinical trials that are going on right now. Some of these are not yet open, but there's a range of trials. We talked about ECOG 2211. There's another study that will be opening hopefully shortly with lanreotide versus temozolomide in pancreatic neuroendocrine. I mentioned the davitinib study. There's a study with aflibercept, which is it's a soluble receptor to VEGF. There's an oral agent called cabozantinib that's under study. There's a study with bevacizumab with two different types of chemotherapy. One is with capecitabine, the other is with temozolomide and capecitabine. There's a sort of a next generation TORC inhibitor, BEZ235 versus everolimus, which is out there. And then a temozolomide endostatin is another example. I just briefly wanted to mention in France, there's going to be a study that isn't open as far as I know, looking at PRRT versus sunitinib in progressive pancreatic neuroendocrine tumors, and a couple of other studies that I have listed here. I also listed a phase 1 study, and the reason I point that out is that historically phase 1 studies are studies that are very preliminary pilot type studies. They used to be done sort of in a mixture of patients. They were often open to a variety of patients with refractory tumors. But what we're starting to see is phase 1 studies that are actually being done in specific tumor types. And just an example, I wanted to point out this study with a drug called MK3475, which is an immunotherapy. And there's actually one of the cohorts in this phase 1 study is for neuroendocrine tumors. One is for carcinoid and the other would be for the traditional pancreatic neuroendocrine tumors. So I think important to keep our eyes and ears open for these types of studies because they do exist. And then finally, I just wanted to mention resectable disease in terms of clinical trials. You heard a lot this morning about surgery for liver tumors, and this is something we always want to pursue if this is an option in the patient. But I wanted to point out what Dr. Chody already mentioned this morning is that despite all the benefits of surgery, one of the challenges is this very high recurrence rate when you start looking at 5 to 10 years later, with recurrence rates that approach 100%. And this is something that really is known. What we don't know to do is how to prevent that, and if anything could be done to prevent that. So one of the strategies under investigation right now is looking at whether everolimus, which I mentioned earlier, the Mtor inhibitor, could potentially be of value after you have resection. So this is patients who have resectable advanced disease who are then, this study is open and accruing right now. Within a certain window after recovering from surgery, patients in this study would be randomized to receive a year of everolimus versus placebo. And again, we don't have any data yet whether this strategy is beneficial, but the goal with this type of strategy is to see if we can reduce or delay recurrence in patients.